Now we'll move for the second lecture about what's titled Why an Early Use of SGL2 Inhibitors in Type 2 Diabetes Management by Professor Antonio Ceriello from Italy. This is also a recorded lecture.
Hello, everybody. I'm Antonio Ceriello from Italy. I'm very sorry that I was unable to join physically this always very interesting meeting. Today, my role is to share with you the evidence suggesting why an early use of SGLT2 is very important in the management of type 2 diabetes. We know that an optimal comprehensive management of diabetes includes glycemic control, weight management, managing comorbidities, and also all these should be reached avoiding a side effect, particularly the risk of hypoglycemia. If we look at the glycemic control, we have evidence that an SGLT2 works very well in reducing blood glucose is there. We cannot forget that the SGLT2 inhibitors were born as hypoglycemic agent. And we have evidence that this is true alone or in combination when SGLT2 works in reducing hyperglycemia. And this is the case for canagliflozin, for dapagliflozin, for empagliflozin, and finally also for ertugliflozin. However, it's very important to underline that today the concept of optimal glycemic control is over just to control for A1C. You see here that today, when we speak about the glycemic control, we not only speak about fasting glucose and A1C, but also about the control of postprandial hyperglycemia, either at 1 hour and 2 hours, how we recover from hypoglycemia, the variability of glycemia in a short and long term, and the most recent attention is now paid to the timing range. Why? Of course, timing range means how many time somebody with diabetes spent in a normal range of glycemia, and this, of course, is very relevant for the glucose control. And this is why, in this picture, presenting the Vitruvian Man, which is a drawing by Leonardo da Vinci that I believe many of you know as one of the most important, not only scientists, but the genius of ever. It is represent the perfect measures. And my intention is to show in this way that for the perfect management of a hyperglycemia today, you need to control not only fasting and glucose and A1C, but also all I have already described. So it's, I think, very interesting to know that this class of compounds is able not only to reduce fasting glucose and A1C, by definition, they were approved as a hypoglycemic agent, but also to improve the situation for all these new aspects of glycemic control. So when we use an SGLT2, we do not only are able to reduce fasting glucose at A1C, but also to improve all these modern aspects for a comprehensive glycemic control. I think this is very relevant. Another important topic is weight management. You know, of course, that today GLP-1 receptor agonists are very good treatments, but when we use an SGLT2, we also get a reduction of body weight. You see here that this is true for CANA, it's true for DAPA, it's true for empagliflozin, and also for ertugliflozin, And at the end of the day, this meta-analysis confirms that also this property is common to all the compounds in the class. So the SGLT2 are able to reduce body weight in people with diabetes. But what about comorbidities? Because of course, we know that how important is to control and prevent the appearance of comorbidities in people with diabetes. And now we have a clear evidence that the most important cardiovascular disease and complications in diabetes are heart failure and chronic kidney disease, which altogether represent almost 60% of comorbidities that can be present in a person with diabetes. And this is not surprising because we learned, particularly in the last years, how the kidney and heart are cross-talking. So if one of the organ is impaired, this also affects the other one and vice versa. So it's clear that today we speak about cardiorenal disease, and a comprehensive treatment of comorbidities must include the treatment and the prevention of these comorbidities. Not only because, of course, they are very important complications, but also because the presence of these comorbidities paves the way to high risk for death. So it's clear that we need really to do all the best we can to prevent these situations. And of course, we know very well that an SGLT2 inhibitor is able to reduce the hospitalization for heart failure, and this is very a common property to all the compounds in the class. So, and today we know that an SGLT2 inhibitors can work in any situation of heart failure, from preserved from a condition of preserved ejection fraction to reduce ejection fraction, and also to prevent the kidney complication. So very helpful treatment. But in diabetes, we learn also about the existence of so-called legacy effect of metabolic memory, hyperglycemia, which means that what happens in the first years, in the first period from the diagnosis in terms of glycemic control can last even for long term in conditioning the risk for complications. The first evidence was coming from DCCT when the people after almost 20 years were showing still a good benefit in terms of reduced risk of cardiovascular disease in those who were intensively treated from the beginning, but also confirmed type 2 diabetes by the UK PDS. Particularly in UK PDS, we learned that this is very relevant for type 2 diabetes. What means the metabolic memory? It means that we have epidemiological and prospective data supporting a long-term influence of early metabolic control on the clinical outcomes. It's like that the early glycemic environment is remembered in the target organs, eye, kidney, heart, extremities, and so on. So the concept of metabolic memory is of diabetic vascular stresses persisting after glucose normalization. And this is just a representation of what means this concept. You see here that this study was receiving an intensive treatment, and within 1 year of people who were not receiving this kind of a treatment before 1 year of treatment, see here how it was impacting even after 6 months from the diagnosis. But the stronger evidence is coming again from the post-hoc analysis from UK. You see here that in this post-hoc analysis has been demonstrated that if you reduce 1% A1C almost at the diagnosis, you get the green line. If this happens after 5 years, you get the blue line. If this happens after 10 years, you get the red line. I think that any comment is really not necessary, that an early control is very important, preserving for the risk for complications after so many years. But very recently, a further evaluation has been published showing that this effect is lasting after 24 years. 24 years is a very long period. If you think that what we do today can last at diagnosis, can last for 24 years. However, we were wondering, in UK PDS, you have data regarding the treatment with metformin, with the insulin, with the sulfonylureas, because these were the drugs available at that time. But, recently, some other drugs have been introduced in the therapy, particularly the SGLT-2 inhibitors, which were at that time not available. And we were wondering, what are doing the SGLT-2 inhibitors on the metabolic memory? Do they have any effect? We use the huge database available in Italy. You see here, we are following a lot of people with type 2, type 1 diabetes. This registry started 20 years ago. So we selected people who were free of any complications at the beginning of when they entered in the study, and to look at what happened when an SGLT-2 inhibitor was introduced within 1 year, within 2 years, or within 3 years from the diagnosis, in terms of legacy effects of hyperglycemia. And we were able to confirm the existence of this phenomenon also in our database, but for the first time, particularly clinical relevant, we were able to show that an SGLT-2 inhibitor, if introduced within 2 years from the diagnosis, can prevent the appearance of the legacy effect of hyperglycemia, the so-called metabolic, which clinically, of course, is very relevant because you see that this kind of approach was working even in people who kept the A1C not at the target during this period. So clinically, this is a very important information. Of course, this is a clinical evidence coming for retrospective evaluation. And anyhow, the conclusion of the study was that these findings advocate a wider range and, wider earlier use of an SGLT2 in the treatment of diabetes. We were also wondering, how can an SGLT2 work on this? And if you look at the pathophysiology of the metabolic memory, we have evidence that the key mechanism is the overgeneration of free radicals at the mitochondrial level due to hyperglycemia. This is the first step in activating several other pathways, leading at the end to epigenetic changes at the level of DNA. And this also can explain why, if you intervene within 2 years, you have some chance to avoid the appearance of metabolic memory. Why, if you intervene too late, this chance is lost. Why? Because an SGLT2 is a very, very good modulator of intracellular antioxidant of, let's say, defense against free radicals. This is a very recent achievement in the science, meaning that the SGLT2 receptors are involved in the modulation of free radical protections of the cells. And if you block them, then improve this possibility of the cells to be protected. So this is probably the most reasonable explanation of our clinical results. On the other hand, also I introduced the concept that SGLT2 can work in this way, meaning protecting the cells from free radicals, in terms of protecting also the tissue from the damage of hyperglycemia. Because you know, it's well known that hyperglycemia at the mitochondrial level is producing an overgeneration free radicals, which in turn activate several pathways leading to diabetic complications. But we have also evidence that all the other aspects of hyperglycemia I share with you are also activating the same pathway. So in other words, these pathways, let's say, this different aspect of hyperglycemia, they are over the chronic hyperglycemia in activating the same pathways. And this is why amplifying this process, there is a higher risk for diabetic complications when you have, for example, glucose variability or hypoglycemia and so on. But also this explains why an SGLT2 can protect against this aspect of the glycemic control. Finally, I think in terms of some clinical evidence, this recent paper is very interesting because it's clearly showing in clinical practice when an SGLT2 inhibitor is added as in combination, is very helpful in preventing complications. So also clinical evidence from the real world are supporting experimental models. What about the safety? I think that I spent only a few words. It's well known that the SGLT2 inhibitors are very safe in terms of hypoglycemia. So it's a really a good advantage in terms that it's easier to control glycemia with these drugs because it's very low the risk of hypoglycemia. This is the 2024 standards of care from ADA. And you see that in one side, you have the suggestion that when a heart failure or cardiovascular disease risk or chronic disease risk is present, an SGLT2 should be considered independently from the level of A1C. But this is what is recommended in this standard of care from ADA. But we have also, on the other side, still the need to look for a glucose control. Totally, but as shared with you, the glucose control today means something else, means a comprehensive control of glycemia. And SGLT2 is also good for this, as well in avoiding the appearance of metabolic memory. So it's clear that introducing an SGLT2 as early as possible, you could be able to tackle all the aspects of a modern management of diabetes. And this will help to harmonize the gluco and cardiocentric approach for the management of diabetes. Some years ago, I suggested that in the same person, of course, you may have both conditions, cardiovascular and renal risk, disease risk, as well the need to control glycemia. At that time, according to the evidence, my recommendation was to use a metformin plus, maybe, for example, a DPP-4 inhibitor there if this risk was not present, but to use an SGLT-2 or GLP-1 receptor agonist if the people were at high risk for cardiorenal complications. I believe that now it's time to move, because according to what the evidence has shown, SGLT2 must be used and must be recommended at any level of the therapy, also to harmonize the glucose cardiocentric approach for the management of type 2 diabetes. And this position has been accepted and recently published in Lancet.de, where at the end, our group suggested that according to the evidence we have, all the evidence we have, we can support the possible benefit of an early use of SGLT2 inhibitors in diabetes management. So, no doubt, the evidence is there. The use of SGLT2 can make the difference for the treatment of diabetes today. Thank you very much.